On behalf of the TBPPM Learning Network India team, I'm delighted to warmly welcome you to today's webinar, Let's Talk TBPPM, second on its series. Our focus today is on a vital aspect of TB care delivery in India, the role of pharmacies in TB service delivery. As many of you know, our TBPPM Learning Network, it's an online community of practice in the PPM sector, where we enable cross-learning, encourage peer-to-peer learning, and also document various best practices in the PPM sector. As a community, we are been organizing various webinars in the TBPPM area. So today, as you know that we look forward to a meaningful discussion today and hope this insights shared will help us all advance in a collective fight against TB. So before we begin, I'll just give some logistical announcements. The duration of the session will be around 11 to 12:30. Interaction, please, audience, use the chat box for the questions or comments during the presentation. And this session is being recorded and will be available on the TBPPM website on a YouTube link, which will be shared to you later. So we are thrilled to have an excellent lineup of speakers with their presentations, followed by a panel discussion who will shed light on this very critical topic. Without further ado, let's begin. I'll invite Dr. Manjari to deliver the opening remarks. Before doing so, I'll just give a brief overview of Dr. Manjari. She's a former Vice President of Indian Pharmaceutical Association and International Pharmaceutical Federation. She's a leader in advancing pharmacy practice in India. As chair of FIP's Antimicrobial Resistance Commission, she has pioneered initiatives such as Public-Private Partnership for TB Control and a campaign on responsible medicine use. An accomplished author and columnist, she has received numerous awards, including FIP Fellow Award, Ishidate Award, and the Best Professional Award from India's Ministry of Health. Nationally recognized as a woman on a mission, Dr. Gareth continues to champion the role of community pharmacist in global health. Welcome, Dr. Manjari Gareth.
Thank you so much. Thank you, Dr. Mona. Thank you for this kind introduction and good morning to everyone. Apologies, I joined a few minutes late. And am I supposed to share slides, Mona? Or
yeah, you can share, Doctor.
Okay. I will recommend if you can join, if you can share the slides.
Okay.
Can you?
Yeah. Yogi?
I'm bringing everyone the greetings from Indian Pharmaceutical Association as well as from International Pharmaceutical Federation. I'm extremely thankful to TBPPM Learning Network for keeping today's webinar especially focused on the role of pharmacists and role of pharmacies in the TB control efforts in India. We have been working towards this since like 2005, and our efforts will be told to you, the story will be told to you by Dr. Raj Vaidya pretty soon. And I'm extremely delighted, especially delighted to have this webinar in this particular week, which is our National Pharmacy Week. Indian Pharmaceutical Association, the oldest professional association of pharmacy professionals in India, we organize the National Pharmacy Week each year in third week of November. And this is 63rd National Pharmacy Week. Each time we have a specific theme, and the purpose of the theme is, can I go to previous slide? So purpose of the NPW is always to create awareness about the pharmacy profession among all stakeholders. So this time's theme is Think Health, Think Pharmacy, which is the global campaign developed by International Pharmaceutical Federation, and we are taking it forward in India. Next slide. And the pharmacists world over have been doing a lot of service to the patients, and in addition to selling of the medicine, they have been providing wide range of health services like measuring blood pressure, measuring blood glucose. They are giving counseling for the medications. They are even into the de-addiction services like smoking cessation program, opioid substitution, and vaccination. In 56 countries across the world, pharmacists themselves are delivering the vaccine, not only creating awareness about the immunization, but they themselves are administering the vaccine. So the community pharmacy services have gone way beyond our imagination world over. In India, we are still struggling to create that kind of atmosphere. We are trying to convert the trader role of the pharmacist into the healthcare professional. In area of TB space, we have done some work and we did the public-private partnership engagement. So we with the help of all the stakeholders present here and all other partners, we will definitely try to improve the community pharmacy services in India for the benefit of the public health. This week, next slide. This week is also very special. So as I told you about the Think Health, Think Pharmacy, that is the NPW's theme this year, and that is coined by International Pharmaceutical Federation. And to achieve the sustainable development goals, we need to engage the pharmacies in every public health intervention, and universal pharmacy coverage will definitely lead to universal health coverage. That is our strong conviction as a pharmacy leader in our country as well as at international level. Next slide. This week is also very special because this is World Antimicrobial Resistance Awareness Week. And when we talk about TB, XDR, TB, and MDR TB, everyone knows how much struggle we have in area of XDR and MDR. And so I'm really thankful for keeping this webinar in this particular very special week. And we are going to talk about, next slide, please. In this particular webinar, next slide. We are going to, yes, as Dr. Mohana said, we have excellent speakers. We have 3 speakers here who are going to talk about their experiences with TB with pharmacies in area of TB control. So I invite the first speaker now, and we will have question answers. So I invite also appeal everyone to put your questions in the chat box so that we can ask those questions during the panel discussion. So thank you again, and I welcome you all, and let's go to the first presentation now. Thank you so much. Dr. Ravindra, I think that is the first one.
Yeah, thank you.
Thank you very
much. I welcome Dr. Ravichandra, is a senior medical officer and head of the training division at the National TB Institute in Bengaluru. With over a decade of experience in TB training and research, he leads national and international programs to develop skilled TB program officers and master trainers. An alumnus of Mysore Medical College, he has authored numerous research publications on TB elimination, diagnostic pathways, and private sector engagement. Dr. Ravichandra is a key resource at NTI for advancing TB capacity building initiatives across India. Welcome, Dr. Ravichandra. You're muted, sir. Hello? Yeah, you're on mute.
Yeah. Involvement of pharmacies is one of the important aspects of TB control. We will come to know as the presentation is progressing. And National Tuberculosis Institute had tried during the times of, say, one and a half decades back. We had a project where we wanted to involve the pharmacists to keep the medicines there, but somehow we could not get the permission at that time. So DAIs we involved, pharmacists we were very much eager to involve. So, and now of course there are so many research publications, and we have understood the importance of role of pharmacists in TB elimination in India. So next slide, please. So we know the vision. The vision is 80% of TB incidence rate should get reduced as compared to 2015. 90% mortality should come down. So 34 should come down to 3. So, and catastrophic expenditure because of TB has to come down to 0. So we are now reducing the TB incidence rates at around 2.5%. A decade back, it was reducing at the rate of 1% per year. So we have achieved around 2.5%. Actually, the actual reduction we were aiming at was 15%. If we can reduce the incidence of TB each year by 15% each year, if it is reducing, it is possible that we will be able to achieve what we are aiming at. But we are far from it. You all know that the COVID has pushed us back in all our efforts. Though the efforts were harnessed in the right direction, we did everything, but we could not achieve it because of the intervening period of COVID. Next slide, please. So the TB disease and its impact, we have understood the role of private practitioners. So earlier, for decades, the program always concentrated on the public sector. When we wanted to end TB, we know that half of the cases are being diagnosed in the private sector. Till today, nearly 75% or 70% of all the patients, the first contact is a private practitioner. And the private practitioners, we have to involve them. They have to do everything that a program does, but there are many deficiencies because they are not exposed, because there are so many other diseases they are caring for. TB is not the only disease that they care for. There are deficiencies in the way they manage. They are not sensitized about the guidelines and the changing guidelines, which are changing very, very fast since 2016. So these sensitizations is not happening as expected. So when they are not having the full picture of what is happening at the national level, programmatic level, there will be difficulties. And to involve them, there is a need to sensitize them. There is a need to convince them that they have to follow the guidelines that are given by the national program. So for doctors, involving them is a difficult thing. Many a times, if I tell a neurologist or a cardiologist that you should not do what you are doing, you have to do this. So naturally, the clinical ego will come in between, and it is very difficult to involve. So there are many other things also. So they are so busy. And if I ask them, you have to notify, it is a cumbersome process. So we are actually trying our best to involve their assistants in the work of notification. So this is our first thing. So when there are so many gaps to involve, so more than 50% of the patients will never come to the national notification register. So we will have handicap. We will be totally handicapped in planning the program. It is very difficult to plan. It is difficult to execute the program. It is difficult to end TB program. Earlier, whatever the patients that are coming to the public, we were taking care as per the guidelines. So that is not enough. In a district, there are patients, half of them are coming to public, the other half are going to private. So we have to catch hold of each and every patient and give them just 1 minute. So we have to plan accordingly, and we have to reach out to all the private practitioners. So what we thought was, whichever the hospital, wherever the patient is going, finally they have to come to one place that is common to all. Instead of going to each house, it is easy and very feasible to approach the doctor. Instead of contacting each and every doctor, it is very easy to go to a place where all the patients, after visiting or consulting a physician, go there. Which is that place? You all know, any patient who is consulting any doctor has to go to a pharmacy. If we can catch hold of the pharmacy, and if we can implement our program at the pharmacy level, we will not be able to, the patient will never get missed. So this was a concept. So there was a lot of discussion. Next slide, please. So there are around 7.5 lakh pharmacists. So it is not fully involved, a very good resource. And if we can target the pharmacists and involve the pharmacists, then it is possible that even those doctors who are not properly referring, they are not notifying, all of them will come to our fold. It is very easy. It is an indirect method of involving all the pharmacists. So actually in Tamil Nadu, in one of the temple town, one of the DTOs was telling that with the help of DC's order, so all the pharmacists, they were reporting all the cases of TB where they get the prescription from the private practitioners. So this is a wonderful method of controlling TB. There are so many researchers. Of course, Dr. Saurabh is going to tell about our own research that we did in Mangalore city in Karnataka. So next slide, please. So because of the government initiative of notification, private notification have increased 6 times as compared to 2016. So it is not enough. It's because the notification was almost zero or very, very less from the private sector. We have to involve all the private practitioners, and every patient diagnosed in private sector, they should come to us. So there are many patients. I told 50 to 70% are more than that patient's first contact is private practitioner. But in fact, there are poor people, there are many people, before going to the consultant or a private practitioner, first contact will be a pharmacist. They will come with a history of cough. They'll say that I have cough, please give me something. So the pharmacist will be in a position to counsel them, to guide them, to give them medicines where he is permitted to do so, and give them correct directions. So already the pharmacists are working in that way because they have the knowledge about TB. They are cooperating. We want more cooperation from pharmacists, and we wanted to educate each and every pharmacist also. So there should be a channel where these pharmacists can do it, uniform channel, because there should not be any confusion among those who are monitoring it, among those pharmacists who are cooperating with us. It should be a uniform channel. It should be monitorable, so measurable. So that way the program is working to achieve it. Okay, where the pharmacist, what is the scope of engagement, where exactly they can be of help in referral for diagnosis. So when the patient comes with a history of cough and he says, I have cough of more than 2 weeks, if the pharmacist is aware that this patient might be suffering from TB, he can refer to an appropriate place where TB diagnosis is done. If TB is ruled out, that is a different thing. They will take care of it, whatever the disease it is. But the first contact has to be efficiently doing it. Unless the pharmacist directs them properly. If he gives a cough syrup and sends off, so he will come back again till the cough syrup is over. Maybe it takes a week or so. And if this continues of a gap in the diagnosis, then he is going to infect another one person. You know that if a patient is undiagnosed, he is a pulmonary patient, an open case, it is possible that these patients are spreading TB disease. 10 to 15 people are infected by an untreated patient in a year. So in an average, if you say each month, one patient is infecting another one. So this is what the harm that is being done if the diagnosis is delayed. See, if the pharmacy is the first contact, usually in many places, in most of the patients, if we can direct them properly, so it is possible that we will achieve a better thing. And after that, once the patient is diagnosed, so they are not notified. So patient is given a prescription, they will come to the pharmacist. At that time, the pharmacist can notify these patients. There is a remuneration that is being planned. And treatment, patients can be wonderful dot providers. So there is no, actually, there are stigmas prevailing in the country, in the rural areas, even in the urban areas, even among the educated people. But if they are going and getting their medicine in a pharmacy, nobody will come to know. So they have their stigma. They are sensitive about it. So we are not touching the raw nerves of the patient. So they can easily go and get their medicines. And the government is planning to, there are studies that are going on. There are schemes to involve pharmacists. So where the pharmacists can keep the drugs and they can act as TB dot providers, so that he will be giving the, in fact, they are called as now treatment supporters. So treatment can be taken care. In the same way, if they have good knowledge, the patient can be sent for follow-up to the appropriate physician, and post-treatment follow-up also can be done with the help of STS. So these are all the advantages and where the pharmacist can be involved. Next slide, please. So referral of presumptive TB patients. So the retail private pharmacies, they are going to be very useful. The study that was done in South Indian district, that showed that less than half of the respondents had pharmacy qualification. But it is heartening to know that half of them, they know about TB symptoms. They have learned by work. They are working there in the pharmacy, they know. So the pharmacist may have some workers who are there who are taking care of the pharmacy, but still they are aware about TB and they are referring them. And so self-referrals are very common. You know that the patients refer themselves to a pharmacy. They come there. And it is found in this paper that rural retail private pharmacies, they usually refer these patients. They can understand that they are all very poor in the rural background, and they are referred to the NTP, the program. Whereas in the urban areas, they refer to the private practitioner. Of course, when they go to the private practitioners, it is the program job to sensitize each and every private pharmacist. Of course, we all discuss that wherever they go, finally they have to come back to pharmacy. That is the center of taking care. They have to come back to the pharmacies. So that is why we want to aim at the pharmacists. Next slide, please. So another study. So this is an important study. So this was done in Tamil Nadu. So where they found that 397 pharmacies in Dharmapuri and 90 of the 1,457 pharmacies in Salem district reported sale of anti-TB drugs. So they are selling it, not that they are not selling it. So upon validation through direct patient contact, so they contacted the patients, 72% persons of Dharmapuri and 863, 52% persons were identified as previously unnotified. That means the private practitioners, they are giving treatment and they are not notified. They are taking the drugs from the pharmacies and they are taking the drugs. We don't know the whereabouts of these patients and how much they are taking. So these patients constituted 20 to 29% of the total TB cases notified in Dharmapuri and Salem district, respectively. Understand, 20% and a maximum of 29%. They are taking treatment and they are not notified. It is a very sad state. Actually, every patient who is coming to the pharmacy should get notified. And it is a very, very important nerve center where you can aim at to bridge the gap. So if 30% of them can be notified from the pharmacist, it will be a wonderful thing. So there is a mechanism. There is a drug inspector where these pharmacists, they can give a copy of this prescription to the drug inspector. They can, the prescription can reach the DTO and the DTO can contact the respective practitioners for notification, or pharmacies themselves can notify. Each notification will give them 500 rupees from the program. So these are all the advantages. There is a need to tap all these things. The resources are there, so they should be taken care of. Next slide, please. So there in the program itself, the pharmacies, they are actually there everywhere, even in the rural areas, even in those places where the government mechanism has not reached. A small practitioner is there to support the practitioner. There is a pharmacy here. So they can be utilized to store our drugs. So they can keep the drugs. They can give out. So that is the advantage. Wherever there is a deficiency in the government mechanism, the private and these schemes and the pharmacies should chip in so that we will be able to take care. Thank you. Next slide, please. Another study where the community practitioners, it was done by the College of Pharmacy in Bangalore. So they wanted to motivate the pharmacists. So out of the 125 community pharmacists who were motivated, who were trained, 93 community pharmacists enrolled themselves as private dot providers immediately after the program. That is wonderful, actually. They are sensitive. They can understand the need of the hour and they can be used. So they can be used. This is the advantage. So when they are trained, when they are given the information, they are ready to serve the country for ending TB. Next slide, please. So there is another REACH program which has a pharmacy initiative. They are involving the pharmacies. So these are all such projects will help the program to end TB. So thank you very much. Next slide. Thank you, sir.
Thank you, Dr. Rajvaidya, for such an insightful session. We now invite, Dr. Vichandra for the insightful session. Now we invite Dr. Rajvaidya, is an accomplished pharmacist with over 3 decades of experiences as a chief pharmacist and a partner at Indu Pharmacy, a family-owned community pharmacy in Panaji, Goa. He currently serves as Vice President and Chairperson of the Community Pharmacy Division of Indian Pharmaceutical Association for the term 24-26. And an observer on the Executive Committee of the Community Pharmacy Section of the International Pharmaceutical Federation. In addition to his leadership roles, Dr. Vaidya is the project leader for the FIP-IPA vaccination project for pharmacists in India and has been the editor of the IPA CPD's e-Times since 2015. His contributions to community pharmacy include involvement in impactful initiatives like the IPA TB Fact Card Project and IPA DOTS Pharmacist Project aimed at enhancing pharmacists' role in TB care. With a distinguished career marked by his commitment and advancing community pharmacy in India, Dr. Vaidya is recognized for his expertise and dedication to public health and pharmaceutical practice. Welcome, Dr. Rajvaidya. The floor is yours.
Yes, thank you very much for the kind introduction. Thank you for having me for such an important session that's it's talking about pharmacists. We're very happy to be part of this, and thank you, Dr. Ravichandran, for giving more insights into this. And this is exactly what we want to move towards. So my title is based on the theme that is there for the National Pharmacy Week. And the intention of having this theme is to make further awareness about the pharmacists in the country. Pharmacists have huge potential, and unfortunately, that they are not too well tapped. So, in my talk, I will let the viewers, participants think about pharmacists in the private sectors. We have retail or community pharmacies and pharmacists working in them. We have hospital pharmacies working in the private hospitals, and we also have clinical pharmacists, which is a relatively new uh, breed of pharmacists, most of them having PharmD qualifications or M.Pharm pharmacy practice. So they are more clinical experts. And in the public sector, we have pharmacists in the National Tuberculosis Elimination Programs at different levels. And we also have pharmacists in the different public health pharmacies across the spectrum, right from rural medical dispensaries to government hospitals, tertiary hospitals, as well as teaching hospitals. So this is a wide range of pharmacies which can be used as resources. So I will give you a brief about the DOTS TB pharmacist projects that pharmacists have been involved. And as can be seen from the slide, this has been valiantly led by Manjiri Gharat, who has been the project team leader and the DOTS TB under the DOTS TB pharmacist project. And because I have been closely associated with that, but she has been the pioneer in this. And this is what we have to present for you. So it was in 2005 where we got involved in the TB fact card project, where in the community pharmacies, we provided this fact card and created awareness amongst the public with the help of the pharmacy students. So this got very good response. And at the end of that project, it was a small project, it gave us quite good results, and it gave us understanding and insights, as well as provided there's confidence that pharmacists can play a role in TB as well. So we felt that pharmacies can and should have a much bigger role, and that they should be part of the national TB program, and they should also be DOTS providers. Because the fact was at that time that other than pharmacists, all of them seemed to be DOT providers. So it was even school teachers, shopkeepers, and NGOs were community DOT providers, but not pharmacists. So we thought that that was a very untapped potential. So we went further into that because we thought, that's what Dr. Ravichandran has said, pharmacists are the first point of contact. So a lot of people visit them, and it's a point for early detection. The pharmacies, a lot of them are open for long hours. They are located at every other spot, especially in the cities, and very convenient locations. And we are quite friendly pharmacists. You don't need special appointments to meet pharmacists. So they could have easier access to services of pharmacists. So they were ideal centers for patient-centric DOT services. They could also share the burden of the RNTCP staff. It was RNTCP back then, and that would help to improve the rational use of medicines for TB and also reduce the cost of care for the poor. So pharmacies do have a lot of advantages. That's a private community pharmacies. So what we did then is that we initiated this process. We had meetings with different stakeholders that involves the TB officers in the state and the city. This was basically initially based in Maharashtra with the FDA as well as local chemist association. So, everybody was a little apprehensive about the new concept, but they all agreed that we should take this forward. So the small beginning was made in 2006, started with training of 6 pharmacists, then further additional 20 to be DOTS providers. The training was provided by the TB officers in Mumbai, and this soon led to their felicitation of these pharmacists because they had been DOTS providers and it was going on very well. Some of the pharmacies had 8, 10, 20 DOTS patients under them. Now, this led to another partnership. This was under the pharmaceutical company Lilly. This was the MDR-TB partnership. So here again, we had a 2-year project, again with the involvement of many players. That is the International Pharmaceutical Federation, also the Southeast Asia Region Forum of Pharmacists, of course the IPA, Lilly, and Chemists Association, and of course the government TB officers. So under this, we also could further enhance the role of community pharmacists about TB and DOTS providers based on the training given to them. Then they were asked for referral of chest symptomatic cases, and then they were provided with DOT boxes based on the referrals from the health centers, government health centers. So they were able to provide information along with the DOTS treatment to the patients. So this was part of the leaflets that we produced for the patients. And this was the form developed along with the TB officers for referral by the pharmacists. So this was made specifically for the pharmacists to refer them to the nearest sputum examination center or the nearest health center, public health center, so that the patients could visit there and get further diagnosed or confirmation of diagnosis. So these were the boards provided by RNTCP, recognizing pharmacies at DOT centers, of course, for the patients also to see, and such boards were also there outside. It's provided by the TB cell. So these are examples of pharmacies who were DOTS providers. So it fitted in their business model, and they did this free of charge. And of course, they got small remuneration for each patient completed. So this was the wide publicity that we got for this project. So it also drew international recognition. So this was an example of a visit by a Vietnamese team to look at the DOTS project in private pharmacy. So private pharmacies had social satisfaction that they were doing this. They felt that it enhanced their credibility at the local level and also at the local government level. So they had free training and continuing education about TB. That was an advantage, and there was a lot of recognition and felicitations for them amongst in the community. So the WHO FIP joint statement, this was also signed in India. Of course, this was part of the international conference, the 99th one in Hyderabad in 2011. So beginning with 6 pharmacists, by 2012, we had 500 plus pharmacists who were trained and became DOTS providers. So we moved forward for further integration of this model in the National TB program. And this led to success where the Central TB Division announced a policy to engage pharmacists, community pharmacists in the TB program. So this was followed by an MOU, formal MOU between the Central TB Division as well as the IPA and the Chemist Association, Pharmacy Council of India, and SIA Farm Forum. So this was a good move and a base for expansion of the model to other states. We did go to other states, and in the next year we had this training module which was developed by the RNTCP for community pharmacy. So this is the first and probably so far that's the only one which has been produced for pharmacists by any of the national health programs. So that's what I said, pharmacists are still not well utilized. So this has a detailed training module providing plenty of information. So this paper, these experiences were presented at several international conferences, and it got worldwide recognition for this. A lot of people from international level look forward to this private public mix of partnerships. So we had reached, in around 10 years, we had reached around 300 plus pharmacists across the country. So some of the highlights were that pharmacists, many of them like this socio-professional work. It's not that it gave them tremendous profits. The DOTS medicine delivery and patient supervision, we thought that it was good. This was our observations. We found that good rapport between pharmacist and patient. Documentation by the pharmacist was okay. They had to document all the dots, things, medicines that they provided to each patient and also follow up with them. And the new tasks fitted quite well in the pharmacy routine. The referrals we felt were okay, but they needed to be improved. NTP staff and the pharmacist repo was good. Felt that the NTP needs to give more attention to community pharmacies for getting better results. So the pharmacists contributing to TB program and benefiting the patients, TB patients, this was one of the highlights. So we had started with a small initiative, but ultimately it led to a big policy change. So National Pharmaceutical Association really felt that can play a significant role in public health programs and policies. And pharmacists could be looked upon as new pool of human resources from public health. So this sort of a thing went around till 2018. Then, of course, DOTS concept was changed. So actually, currently now, none of these pharmacies are actually DOTS providers. But as Dr. Ravichandran was saying, something is being worked out. We are very happy to work on that. So we documented all our experiences over the decade in this document, Pharmacists at the Front Line. It was based on the DOTS TB Pharmacist project for over a decade. So IPA has documented this and released this book, also available on our website. So coming back to the topic that I had made, based on all this, based on this experience that we had in community pharmacies, what I would like to reiterate that pharmacists are underutilized professionals, especially very much so in India. The roles for pharmacists are unfortunately not defined or listed in most of the national health programs. There is luckily something under the TB program. Then, when coming to these public health centers where pharmacists work as dot providers, the workload is a lot, and often there is a single pharmacist to handle the pharmacy, the inventory, dispensing, as well as the dots provision and doing the record copying. So the pharmacist cannot pay sufficient attention to do additional work for TB. Then the TB pharmacists under NTP, this is the situation in Goa. They are paid 12,000 a month, and I think that's a temporary contractual post. I inquired a few months back what pharmacists in other states give. So there is some 14,000, 15,000, 18,000, but I feel that is quite much less. And if we want the pharmacists, even in the public sector, to perform better, I think they need a little more motivation than this. Now, suggesting some role enhancements for pharmacists at one point at all levels in the state, central, and TEP, and at the all public health pharmacies, public health hospitals, increase remuneration, give additional responsibilities. Presently, they are given some minimal responsibilities, but they are capable of doing much more than that. They only need a little additional training for that. We need to involve them in inventory management that and quality assessment and quality control, because that's what their expertise is. Also involve them in patient counseling, follow-ups, and adherence to treatment. Right now, I think they're not getting sufficient role play to play in this sort of sector, but they can perform very well in this. They can also be very good at supervision of the program. Then the clinical pharmacists, very important to involve them also, because they can take a very good part in with their clinical expertise in collaborative care in both the private sector as well as public sector in TB patients who are hospitalized, as well as TB outpatients in both private and public sector, because they can be involved in medication review, assisting in making treatment plans, drug interaction, managing side effects, drug information, and counseling and follow-ups. Some challenges which we feel as community pharmacists that we face. I myself, as a practicing community pharmacist, we stock and dispense TB medicines. We are one of the few pharmacies which do that. Many of the pharmacies have stopped doing it, and that's the Goa experience at least. So the number of pharmacies maybe because it's lowered prescription. Of course, the benefit is that there is increased coverage by the public sector. A lot of information needs to be collected from the TB patient because it has to be notified. So in doing that, the patient is not always comfortable when we ask, including the address and mobile number, which is necessary for us to upload that information for notification of the of TB. We have to do it through an online submission of a Google form, which is provided to us at the local level. But unfortunately, there is no feedback and no acknowledgement, and we don't know what happens to the data that we provide to them. We do not have any access to Nikshay. Then some challenges, additional challenges, we get prescriptions from out of the state for TB medications for continuation, and many of those patients bring their old strips for refill and no prescription. So there we are not able to provide the medicines because we cannot, and some of the TB drugs are also not available, and so it's difficult to track such patients whether they be completing their treatment, how they can get their uninterrupted supply. So there needs to be better integration and better information provided to us. So in concluding lines, I think I will reiterate what Dr. Ravichandran has said. There's need for better interaction and integration of community pharmacies in the national program. We are willing to do that. And I think pharmacists should always be at the table when health is discussed. And of course, when TB is discussed, I'm sure we can do a lot. We are willing to contribute that. And we look forward to being more involved in the process. Thank you very much.
Thank you. Thank you so much, Dr. Rajvaidya, for such an comprehensive and practical insights on pharmacy engagement. It was very invaluable. We truly appreciate the time and effort you have taken to share your knowledge with us today. Thank you so much. And now we welcome Dr. Saurabh Kumar. Saurabh Kumar is a dedicated public health professional and academic with over 13 years of post-MD teaching experience. Currently serving as a professor and head of the Department of Community Medicine at JGMM Medical College in Hubballi. He plays a pivotal role in TB control efforts in Karnataka, including his position as chairperson of the State Task Force on TB for Karnataka since February 2023. Dr. Kumar's contributions to TB programs include serving as a state nodal officer for TB, subnational certification, and as a nodal officer for the RNCTP and TEP core committee at KLE. He has also made significant contributions to supportive supervision and training in TB care and prevention in collaboration with State Task Force and the Karnataka TB officer. Welcome, Dr. Saurabh Kumar. The floor is yours.
Thank you for the warm introduction, ma'am. So first of all, at the outset, I would like to thank IFH Bangalore for giving me this opportunity to share our experiences, what we had, especially in the role of pharmacies and pharmacists as far as TB notification is concerned. So now before sharing my presentation, I'd just like to add a few points, just you can say a reiteration of what Ravichandra sir, my mentor, and Rajveda sir have already highlighted. That how we started. Like if you look in real way, when we talk about public health, it's not just one man event, one man activity. It's always a teamwork we're looking at. So any disease we talk about, it's yes, we have the doctors are there, then we have the nursing, then you have the diagnostic team also, and then you have the integral pillar of the pharmacy also. So these all four pillars are integral component in basically looking at breaking the chain of transmission and to be utilized for whether we're looking for adherence, whether we are looking for notification. And that's what probably the program did in the beginning itself, and we involved them as far as the referral of the presumptive, that time we used to use the word suspect or chest symptomatics word over there. And on the presumptive patients, and trying to refer them to the diagnostic DMCs or the NAT sites over there for the diagnosis. Then the time came when we were talking about the not just the general public, but also looking at the pharmacist also being the dot providers. And because obviously, yes, the stigma was there, and now also we feel stigma is there. And that's the reason they will not be comfortable going to a public setting sometimes. So they'll be comfortable going to a private setting, and that pharmacy, if they're getting the drugs what they routinely get from the particular pharmacist, will be easier for them. And then the second aspect which came was, I think, it was a trial pilot project by ICMR, which was more focusing on uh, if I'm not wrong, it was in Bihar. I don't remember the exact details of the project, where they involved a pharmacist as a pilot project that some voucher will be given to the patients who are having the tuberculosis disease confirmed by the physicians or the clinicians. They have to go to a particular pharmacy, collect the drugs from there because they were not okay with they were not having the, we can say, comfortable going to a government system or whatever the reasons. It was not explored in that study, but they looked at exploring the role of pharmacist in that. And the drugs were given by the pharmacist, and the pharmacist, it was given completely cashless. And then the pharmacists were paid the money from the state. But in long term, if you look at it, definitely becomes not feasible in terms of the funds, like since we have already have in the drugs and good quality drugs available in the government setup. And then we were looking at how we can explore the role of pharmacy in TB notification. So I'll just share my presentation with all of you now. Hope my presentation is visible. Okay. So now it's like our experiences with this project in Mangalore. So how like we involved the pharmacists in TB notification. This study has already been published in Clinical Epidemiology and Global Health, and titled as Putting TB Notification into Practice Among the Private Pharmacies in Mangalore City, India. Did we succeed? I've listed the co-authors and my mentors, Dr. Ravindra H.R. Reddy. He was working in WHO previously in TB at the national level. Dr. Ravichandra sir, you already know about. Sharat sir has been the Zonal Task Force OR chairperson, Operations Search chairperson, and Badruddin sir, was our district tuberculosis officer when we did this study in Dakshin, Canada, Mangalore. So I'll be just trying to present in brief what why we did this study and what the results we got over there in this study with a short amount, or you can say small amount of the money we got from the operational research. So we all are aware that TB was declared as a notifiable disease way back in 2012. But I think all the experts over here with me will be definitely agreeing on this aspect that there was a lot to be asked when it comes to notification from the private sector in spite of making it a notifiable disease. But yes, with the definitely inputs from the program, the various interventions from the program at the state level, district level, and all, and the national level, we were able to improve the TB notifications from what it was 2% 2013 to 30% in 2022 by the private sector. But as told by Ravichandra sir also, I do agree. Many times it is not happening from some of the private sector doctors or the maybe hospitals over there, which again the program is trying to bring them in one or the other way. But the point is, we are still below the targets in terms of notification, what we expect from the private sector. It was one of the studies which was done in Bangalore also by KHPT, which was telling like the first point of contact is usually the private sector physicians only. And there's many times there's a diagnostic delay when the patients are coming all the way to the government setup, like the DMCs for the diagnosis and putting them on treatment. Now, if you look at the WHO task force data also on TB impact measurements between 2016 to 20, this adopted a strategy of strengthening national notification systems. So keeping that in mind, like when we had our monthly review meeting, I was associated with the TB program since 2000, almost 14 in our medical college, and I was working actively with our district TB office official also, as it was my interest in this particular topic. And we used to visit this review meetings also as a part of my project, which another project on TB and diabetes. And then it came up like why not involve the pharmacies in the in the notification of TB cases. But the issue that time, what we were facing was like we didn't have any mechanism, the regulatory mechanism to bring the pharmacies into picture. If we try to like ask, maybe like some pharmacy may agree, some may not agree over there. But it was definitely felt, yes, we have tried through doctors. Now, labs also, like hospitals also were asking to involve the labs, private labs, and the pharmacies too. And luckily, if you look at 2018, we got the Gazette notification over there where we were able to involve, where it was ensured to Annexure 3 and 4, we're supposed to involve the pharmacies also in the TB notification. So the objectives what we took for this study was to compare the TB case notification in Mangalore City before and after the training of pharmacists and reinforcements to the monthly reminder messages using a social media tool. And another objective was proportion of the private pharmacies adhering to the guidelines of mandatory notification of TB cases. We made some operational definitions over there in terms of the adherence over there, trying to ensure that the Annexure 3 and the Annexure 4, which are there, are completely filled. I think Ravichandra has already pointed out it becomes very difficult to extract the details many a times over there. And this was found out a similar study done in a different setting, though in the PPSA model in Maharashtra too, where the details were not completely filled up in the Annexure 3 and Annexure 4 forms. So as I mentioned, it was a before and after intervention study, and we looked at the programmatic data to compare the TB case notifications, and it was in Dakshin Kannada district. So we looked at specifically like multiple TB units. Now presently, if you look in Dakshin Kannada, there are 8 TB units over there. For the information of all the audiences, like yes, we have if you look at the organogram of TB program over there, at the basic level, we talk about the peripheral health institution, then we have the microscopic centers, and previously used to have the DMCs, and now we're all talking about the tuberculosis units, where usually a taluk health officer level staff will be responsible for reviewing the program, and they'll be supporting the district TB office in overall implementation of the TB program. So we looked at 2 TUs, that is Mangalore TU. Previously, it was Mangalore TU only. Now it is North and South TU of Mangalore we are talking about. And why we chose this particular area itself, because it's like Mangalore, if we talk about the geography of Mangalore and the demographic, if I have to talk about, there are about 8 private medical colleges in Mangalore city itself. And there's no government medical college. Yes, we have a very, we can say, government hospital, district hospital, Venlock Hospital, we call it as, and it's wonderfully working with a good patient load. But in terms of medical colleges, yes, private medical colleges only are there. And that's where we thought of like, yes, we have so many of respiratory medicine faculty and general physicians and your medicine physicians also. So why not like look into pharmacies, find out the pharmacies which are notifying the TB cases over there. And we also looked at one step further, though we didn't like do it as a project back, it was more of an informal aspect, whether like to identify and go for the GIS mapping of these pharmacies which are contributing the maximum, and trying to get the support and the overall notification in the program. So how we did it's like we got a line listing of the pharmacies from the Mangalore ADC area itself. So there are 2 circles, Mangalore 1 and 2 circles. And then it was going beyond the Mangalore TU area. So we had to identify which pharmacies are coming in the Mangalore TUs of the Mangalore circle. For the information of all the audiences, just want to highlight the TB units, what we're talking in the TB program are not exactly the same. What we're having the ADC circles, or which is like the assistant drug controllers offices which we have in our Mangalore city, they'll be having circle 1 and circle 2. So it's exactly not matching. So we had to extract out some of the pharmacies from the entire data of around 500 to 600 pharmacies, what we got the list from the Mangalore ADC office itself. It was very difficult to reach to all the pharmacies, and we some of them were not agreeing to be a part of this study, though like it was can say notification had come as a regular notification, and we took a request to our ADC office for permission for this study. Then we took the again the permission this thing we had to take from the Pharmacy Association and Druggist Association of Mangalore City. So thanks to these agencies and the Association of Pharmacists and Druggists of Dakshin Kannada, which supported us like anything for this particular project. We got the approval, and we used to take the letter, like our research assistant used to take the letter of approval from the Pharmacist and Druggist Association of Pharmacies of Dakshin Kannada. Like when we are going in the field to each and every pharmacist, pharmacy or the pharmacist over there for their support in the notification of TB cases from the pharmacies. Now, the field assistant was appointed in the project, and we trained him, and along with district TB officer and the public-private mix coordinator. Now, PPM coordinator, as all of you are aware, like for almost one district, we have one PPM coordinator only. But believe me, like after working in the field for so many years in the tuberculosis, we realize that like with one PPM coordinator, it's practically very difficult to ensure that he's engaging with the private physicians also, all the consultants also, in a place where you have got so many medical colleges and so many nursing homes and the clinics. Along with that, you can say interacting with the pharmacies also, it's definitely a cumbersome job. So like it was welcome by the district TB office that okay fine, as a part of project we're trying to help the district administration also in ensuring that the pharmacists also are brought on the board for the continuous notification or the reporting of TB cases. But we had to exclude the pharmacies of alternative system of medicine, and pharmacies found to be closed and not available due to changes in the address of phone numbers, for which phone numbers were not there. This is the gazette notification, and as I told you, we went for the sensitization, the desensitization process, and sometimes we verified it randomly by during our supervisory visit when I was going along with the PPM coordinator of Dakshin Kannada district. We created a WhatsApp group also with great difficulty, ensuring that only the research part is being discussed in that. And we were looking at reinforcement to the WhatsApp group. So what were the primary data regarding the TB cases? So we're looking at reported by TB, the various cases reported by the pharmacies from before the intervention. And we took the data from April 2018 to September 2019. They started a study in like, you can say October 2019. And the idea behind was the experts were telling us when we're doing this study, like sometimes we're looking at the variations happening in terms of the number of TB cases notified on a season basis also, you may get. So just to rule out that particular thing, let's take the data from the previous years and see whether there's any having significant difference. So primary data, what we collected through the prescriptions and the Annexure 3 from the various pharmacies, we had to verify with the secondary data obtained from the Annexure portal with the help of the district TB office to see like, okay, whatever the cases were reported by the pharmacist in the case reporting format in Annexure 3, like are already notified by some medical officers or some of the labs or hospitals or not. So to avoid basically we wanted to do the process of deduplication over here. So the total of 243 private pharmacies were sensitized during the bi-monthly visits and monthly reminders from October 2019 to March 2020 by our trained field assistant. What we observed was there was definitely increase in the case reporting as well as the average number of pharmacies reporting the TB cases. As you can see from this particular line diagram also, October 2018 to, if you look at, there was a dip somewhere in the second half of 2019 also. Probably that was a seasonal variation we were talking about. But yes, when we had this intervention somewhere at the end of September, we looked at some of the number of pharmacies which were previously not notifying over there, started notifying, I'll say better word, reporting the TB cases through the Annexure 3 and Annexure 4, the district TB office. Now, why I said like this study was really interesting, and like I said, it's definitely a study which was done in the programmatic conditions, and at a very less budget we tried to do this study over there. And we looked at the concentration was in private pharmacies in the urban areas, especially the key region where we're like reporting the almost 40% of the TB cases which were notified in Dakshin Kannada district coming from the Mangalore TB, Mangalore tuberculosis unit, and another 15% from the Moodbidri division of Moodbidri TU, and the remaining cases were coming from the other TUs, where like huge amount of area was rural area also. There is another reason we thought of like having this focused studies instead of diluting the and involving all the pharmacies where it was practically becoming difficult for us to go in the field and try to supervise. Now, as already been discussed, like we just explored how we can take the role of pharmacist in this case and notification. And as I told you, like we definitely got improvement in the reporting, and there were some issues. Like as I said, some cases were already notified by the previous, I can say, physicians or consultants or hospitals over there. So it didn't lead to like increase in too much of notification in the TB cases. Probably I can say like time constraints also was one other thing, because we did this study only for 6 months because of the financial constraints and operational research grant guidelines that we have to only, they will be giving us time limit for some time for data collection, and then we have to go for the preparation of the manuscript for the same. We also had the issue of changing in the contact details and addresses, what we got from the ADC circle and what was with the PPM coordinator. But definitely it helped us in establishing the correct contact details and addresses of all the pharmacies in Mangalore city, at least for us. And the another thing which all of us are aware of, yes, this was a challenge in the later half, like especially though we said like till March 2020 we had to stop this study somewhere in the mid first second week of the March over there, and because of this COVID aspect, and suddenly then we had the lockdown too. Now, what we got of this study, as has been reiterating it, so it led to improvement in the reporting mechanism of private pharmacies. So, as I told you, because of when we did the deduplication, we found that it is not leading to much increase in notification of TB cases in the district. But this step, or you can say this was the baby step which we took. And believe me, like what has come now, like since again, we have also developed a different mechanism, as our previous speaker sir was talking about, Yogi sir was talking about like that having a Google form mechanism. And but like unfortunately, they're not getting the information like what is happening to that information which is collected. So we tried to have something called as Google spreadsheet mechanism, because we already had brought the pharmacist on board with us. We already knew which all the pharmacies are there basically who are selling, or you can say dispensing the TB drugs. And the Google spreadsheet, they were updating it on a real-time basis. So whenever the patient is coming, they were trying to update in that. And what we have done is like one particular pharmacy was given one particular row in that case, and they couldn't alter the data of another pharmacies. There was one issue, definitely, yes, like to, because details of some of the patients will be mentioned over there, one or but not the complete demographic details. Just to ensure that there is no duplication of the cases, we had to ask them to put the demographic details of the patients too. But this process has now helped the district TB office in ensuring that we don't miss out the TB notification. Yes, I do agree from your point. Like I think that sometimes yes, that we may miss out the cases, but it's just, you can say, the steps what we have taken, probably the, if we come to some piloting of different mechanism, like sir said, Google form, are we talking about the Google spreadsheets, or we can come with some app mechanisms also. Nextshare is already there. We can look at some consolidated mechanism or one particular form, or maybe can have two different aspects where we can go for using the this taking the help of the pharmacy association and the pharmacists in also like bringing them, as previously told, we all work together as a team. And finally, our objective is improve the notification. Once we notify them, you're obviously putting them on the treatment and ensuring that they complete the course of treatment, not going for drug resistant TB. And in that, we will be able to break the chain of transmission. Yes, we'll not be able to achieve TB elimination completely, but it will be a big step towards breaking the chain of transmission. So with this, I will try to end my talk. I just would like to acknowledge the source of funding. It was a part of an operational research from Medical College faculty and the NTB program by the State Task Force Operational Research. And it was a project and a manuscript were developed during the protocol development and scientific paper writing workshop, respectively. Thank you very much for your patient hearing.
Thank you, Dr. Saurabh, for sharing such compelling perspectives. We deeply value your practical strategies and evidence you have provided. So now the floor is open for panel discussion. I would like invite Dr. Manjari to take over the floor and initiate the discussion.
Thank you so much, Dr. Mohana. And my sincere thanks to all our three speakers, Dr. Ravichandran, Dr. Raj, and Dr. Saurabh Kumar, for your wonderful presentations and giving us so many inputs. And I can see a lot of interest has been created in our audience who are very keen to know many more of these aspects. Also, before I go for any questions, I also want to acknowledge presence of some of the dot provider pharmacists in our audience. I can see Vijay Kumar Ghadge and Sanjay Sogule. And I want to tell you that these pharmacists have been dot providers for years together, and they have cured many patients. So thank you for joining. Now we go to we have heard the stories of engaging the pharmacist in the National TB program, or what efforts have been taken to improve the notification through the pharmacies. Even the barriers, the problems, issues also have been discussed. There are some of the points which have been raised by our colleagues here. And one of the point is, what incentives can we give to the pharmacists to keep them engaged in such type of activities? Can we give them certain benefits? And that has been the question. So I invite all of you, all the three panelists, to give your inputs. How can we make pharmacists interested to work in this area? What benefits can be given? I can tell my experience at the end, but I would invite all the panelists to speak about it. What incentives can we give to the pharmacists? How can we make them interested to work? This is kind of an additional work for them than their routine work in the community pharmacies.
Yes. Ma'am, can I pitch in, ma'am? Dr. Saurabh here.
Yes, please. Most welcome, sir.
Yes, ma'am. So, ma'am, like as I talked about, like I mean, Sir Ravichandran has also spoken about notification thing. So now what happens is Niksha IDs can be created for the pharmacist also by themselves, which was not existence before the Gazette notification, which came in 2018. Now the only issue comes is like what I've seen in a private, I can say practical experience in the field too. Sometimes a patient has gone to one of the respiratory medicine physician, and he has notified the case from his side. Then that patient goes to another physician or doctor over there. That person also will try to notify the case. And this is another hypothetical example where like it goes to a lab, and lab also suppose in case they notify it. And the pharmacist also notified, but as per the programmatic protocol, the person who notifies first only can be given the incentive, ma'am, in this case. So, but only thing is what we're looking at, if the pharmacists are notifying it over there first, the pharmacists are going to get the notification incentive, ma'am, for this, for supporting the program. And if you ask me my personal opinion, so I will say like, I'm totally against the aspect of giving the incentive. Not just for like pharmacists, for doctors also. It's our responsibility and duty to notify the disease, whether it's a hospital or individual clinics or the doctors also over there. Whatever notifiable diseases have been put up by the government of the state or the government of India, it's our responsibility. We have to notify the respective system to be a part of the effective surveillance mechanism. I'll rest my case with this, ma'am.
Right. Yes. Thank you. So TB anywhere is TB everywhere, and it is everyone's responsibility when it comes to TB reporting or TB notification, or TB diagnosis. Raj, do you want to add something?
Yeah, I agree with Dr. Saurabh.
Dr. Raj?
Yeah, I agree with Dr. Saurabh. And in being part of professional work, I'm sure if involvement of pharmacies itself would be a great incentive for them. I think that sort of recognition, of course, what we have experienced is the same. Now, when they completed one patient by providing dots, they were getting incentives. That is a part. But for notification, I'm not sure whether we should be giving any incentive. The incentive could be in terms of some recognition. I think involvement of pharmacies in this whole project in a much wholesome way would itself give a lot of recognition and incentive.
Yes, thank you, Raj. And I can see one comment by one of the pharmacists in the chat box that it is our national duty and no incentive is expected by the pharmacists. This is incredible, and we are very happy and proud of such pharmacists. But when it comes to the ground realities, not every pharmacist thinks that way. And therefore, as Dr. Vaishali has asked this question, what incentive shall we give? What benefit?
Yes, ma'am.
Yeah, so now our experience, we have been giving the non-monetary incentives to our pharmacists, never the monetary incentive. It only used to come like 500 rupees from the RNTCP, but we were recognizing them by giving them certain boards. So they stand out from the other pharmacies because they're
Yes, exactly. So that is what I was trying to ask, ma'am, because I'll tell you where this question is coming from.
Important, yes.
Yeah, because we are implementing PPSA program in 6 states. So we very much require the support of pharmacies. But what happens is that Many a times, because in Mumbai, there is 100 rupees per month per patient through the program. It was going for few years, and then the program stopped, and now the program has kind of told us that the PPC agency has to start giving that incentive. So in Mumbai we are giving, but then I exactly would say that this is the correct way, that we also don't want to kind of give that 100. So in Mumbai, because it has been a practice, we have to continue. But in the other state, it is not yet a practice. Like we are doing it in Bihar, UP, Assam, Orissa, and also Delhi. So I believe that what is it that apart from money that we can provide them? Because many times when we go to discuss with them, they always take it as an extra headache. Like already so much of work is there and there's no extra incentives. When I mean incentive, non-financial incentives, then how can we or my team convince them to be a part of this? Is what I'm trying to understand.
Yeah, I understand. And all these 20 years, we have been struggling with such questions and trying to find the solutions. So, as I said, giving the recognition, felicitating them on the World TB Day or otherwise, giving them some spatial boards, or saying that this is not an accredited, but something of those kind of terms used, and giving them a nice board which makes it stand out from the other pharmacies. Maybe enrolling them for some conference, talking to them, and interacting with them on the continuous basis and keeping their motivation on. Or providing them some other goodies, goodies which is ultimately useful for the patients through the pharmacies. So some kind of goodies can be given to them which is for the patients ultimately, say like a weighing scale, or some kind of BP monitoring machine or something of that sort. We can think of so many ways. So this will keep their motivation high, and they will feel they're engaged in something special, and whatever they're doing is work. So we have to think, and we have found out certain ways. And in our project also, the dropout rate was like 30% of the pharmacists did not work after their training. But then 60 to 70% did work to a great extent, or to a small extent at least. So I think continuous engagement with them in different ways and recognizing them, keeping their motivation high is very important. It is not very easy, but what I want to say is we should be integrating the pharmacies in the primary healthcare. And if it comes from the top as well as from the bottom, it is going to be helpful. So from the government side also, if we can integrate these pharmacies as in our project, we enroll them in the National TB Control Program, then it would be really good. And we have like around 8 lakh pharmacies in India. And I don't think everybody is going to be enrolled in any national health program. So even if a small percentage of these pharmacists come forward, who are willing, who are always present in the shop, then also it is going to be great benefit to the public health. So we can always give them option, and then they can come forward and then get enrolled for such activities, such programs. So we can continue with these discussions, Dr. Vaishali, even after our webinars. Definitely.
Thank you, ma'am.
Yeah. There is another question from Mr. Anuj Agnihotri. Did any of the study or projects ever used any digital intervention or platform to enter the patient data at pharmacy level while dispensation of the TB medicines? Dr. Anuj, Schedule H1 register is kept by the pharmacist, either in the computerized form or in the hard copy. I would like Dr. Raj and Dr. Saurabh and Dr. Ravichandran to comment. Did any of the study or projects ever used any digital intervention or platform to enter the patient data at pharmacy level while dispensation of the TB medications?
No, in our project, we did not. Sorry. So in our project, we did not use. I think that time the tech savviness was much at a lower level. And in routine dispensing pharmacies, the bill comes, but the details of the patients, as expected by the notification, is not kept in the computer. So a separate H1 register is kept. In addition, we have to note down the details of the patients, at what time, when was the medical treatment started. All those details we have to upload in the Google form. So we do that at the end of the day. We get 1, 2, or 3 patients per day. The numbers are much less.
Yes. And when we are talking about the notification and the reluctance of our TB patients to give all the details to the pharmacists, I would like to emphasize a point that it is important that the more awareness is created in the TB patients or in the society itself, that they should be giving this data to the pharmacies whenever asked. It is their duty. If they're a TB patient and if they're getting the medicines, it is important that they give all the details to the pharmacist, because otherwise they keep on hiding or running away, and then it becomes a difficult job for the pharmacist to get all these details. So we, all stakeholders, the government side, the NGOs, professional associations, through the media, through any other means, we need to create this awareness that it is patient's duty also to give all the data to the pharmacist, and it will not be misused. So I think we should work on that too. Any other question anyone who wish to ask? There are some questions in the chat box also. Before
I want to ask.
Yes, please.
Sorry, ma'am.
Please go ahead. Please go ahead.
Yeah, I wanted to ask, like, is there any GPS mapping or something like that available for pharmacies, so that it will be easy access for for a patient, for a provider, everybody to kind of understand where these pharmacies are located. So, is there anything like that currently?
I think if we, I don't know. I mean, let everyone answer the question. But do you mean that when we put in the Google pharmacy near me or chemist shop near me, we get it? So most of the
So the ones which are in the program, the ones. So for example, say if I'm a TB patient, if at all I see Nikshek, which is the nearest pharmacy that can provide me a medicine, is there something like that which is available?
Not at the moment, unless somebody has started trying it. I'm not aware.
They're not
wants
mapped
to
for
add?
that. They're not mapped for that, but the APDM, that is the digital program of the country, will soon be mapping community retail pharmacies. So I don't know whether we can make a provision in that, whether they are
Shall I make a
TB
point
medicines. Yes, sir.
Yes, please. Yeah.
Actually, all dot providers are the treatment supporters. They have a directory at each of the TUs. So if a pharmacy is providing drugs and the pharmacist is the dot provider or the patient supporter, treatment supporter, so he will be there in the directory, and that directory is available in Nikshai. So this is one possibility that they are all involved. And the other is digitally, they can mark when the patient is coming and they are taking the medicines. Each time they come, they can mark patient has swallowed the today's drugs. That is directly observed treatment either in 99 dots or in the Nikshai portal. There is a possibility of digitally marking it also. And another point I want to make is dot has not disappeared yet. In all the training modules, dot is still there. And during COVID, of course, every one of us know we could not do direct observation of treatment. And some of these measures have disrupted the treatment procedure, whatever that was happening very nicely. So eventually they have to come back and get strengthened. And Saurabh sir was pointing about incentives. So it is our duty rather than doing. I fully agree with Saurabh sir. And one more thing, Government of India has come with the idea of Niksha Mitras. You are not taking from the program. In fact, you are giving to the patients, because the patients who are suffering from TB, and 50% of them, they are actually because of malnutrition. They're because of poverty. Very, very poor people. In fact, if we start giving medicines and proper nutrition, they have to gain a minimum of 6 to 8 kilograms by the end of the treatment. This much is the poverty and malnutrition. In fact, each of us, including pharmacists, if it is possible, of course, they are going to get 500 rupees as per the notification, but they have to give rather than expecting from the program and the nation. And so that way, the TB program is being promoted like a Janan Dolan. So every one of us should know and see to it that the patient, TB ends. So that is the thing of today's trip.
Yes.
Ma'am, can I pitch in, ma'am?
Yes, please. Yeah.
Yes,
Yes,
ma'am.
please, Dr. Saurabh.
Ma'am, to answer Dr. Vaishali's question also regarding the use of the app, like I said, we didn't use the app, but like as a, we can say, continuation of the project, we were able to go in terms of a Google spreadsheet, which almost everybody was having the access to it. But as you're aware, the Google spreadsheet will be again a challenging thing. We had to take the help of the IT, ensuring that a particular row can be filled only by a particular agent email ID only. We had to just lock it. Otherwise, sometimes data will be completely gone.
Yes.
we had this experience over there, then we had to
Yeah.
take IT help and try to do in that way.
Yeah.
But as Dr. Vishali was telling it, yes, definitely it is a good thing like to involve. And it was a project which we were planning, Dr. Vaishali. We were thought of like what we were looking at as identifying and doing a GIS mapping of all the pharmacies like which are dispensing the anti-TB drugs. In fact, in my own experience of subnational certification, and I just echo the words of Raj sir also over there, but he told that now many of the pharmacies have reduced the stocks of anti-TB drugs. And this we found in the various nominal group technique methods when we had the discussions in various districts throughout Karnataka. I was a state nodal officer for this for 2 years. And we found that like most of the pharmacists, they don't want to keep the stock of these drugs now. And for second thing was coming up, like those who are having the stocks also, they said like they don't keep very huge stocks. Whenever the requirement is there, they'll try to get these drugs for the patients. GIS mapping, I have a suggestion. So like from a project side, if you can take it from your side, or for like, I mean, Majri ma'am also, like if you can take it up at the national, really a great help for subnational certification also. If I'm not wrong, we got the correct data of the sale of drugs of anti-TB only from the state of Andhra or Telangana, ma'am. I'm not sure which state exactly. It was discussed in the national level meeting also. And that was one. Second thing is like since the approach of even WHO consultants during the process of subnational certification was trying to get the data from the distributors of anti-TB drugs. What is the sale over there? So what my point was, we'll take it one step further. They will be having as distributors, but distributors were not willing to give the details of like to whom they are giving selling these drugs. That was one of the challenges we faced in subnational certification also. And the DTO office, many times, like when we used to have this nominal group techniques, focus group discussions, we used to get some pharmacies which are not dispensing the anti-TB drugs also in that. So my point is, if we can get this data through your association, ma'am, and along with the, you can say drug control office also, just getting a mapping of all these pharmacies. So it will definitely answer Dr. Vaishali's questions also, and it will be a great project also if we can do it together, ma'am. That is one. And then we'll get in a specific areas, ma'am. Throughout the country, we can get it over there. Like which are the pharmacies which are involved in this case? And maybe like from there, we can have a mechanism of capturing the prescription the way it is done in the retail franchises like Apollo and to some extent in MedPlus also. They have their own app of capturing the prescriptions. But the data goes to their server. If you try to link their server with the Niksha, maybe like the government setup, at least the information of TB cases, it will be really helpful for, we can say, more reporting of the TB cases. But it's a Herculean task, but definitely a big support is required from as a vice president and the president from your association, ma'am, along with the district, you can say, drug control office.
Yeah, thank you. Thank you, Dr. Saurabh. And this has been, always a struggle to get the data from the pharmacies. And I can remember and recollect that for last 10 to 15 years, I'm also in Mumbai and Maharashtra working with WHO consultants and the Clinton Foundation and the Bill and Melinda Gates Foundation consultants to get the data. Then we thought of distributors. Then we went to the drugs control office. And from drugs control office from Maharashtra, we could get some data. But then it's not very easy from the pharmacist to get data, even from the chemist association. And we have tried all those ways, but as you say, we can again try, in a different way with a different approach. And sometimes pharmacies are not very willing to give this data, and they are not very sure what will be happening to this data and why is it asked. And so maybe we can have it more systematic. We can have it done in a very systematic way. By giving them a letter and convincing them. So we can try it out. And I think we just have a few more minutes, but I acknowledge the presence of Dr. Kiran Reddy from WHO. I guess now he had short of time and he had just left. But there is one or 2 points he has raised. I'll quickly read it out. Online or e-pharmacy with drug delivery system can be a big complementary system to NTEP to enhance the people-centered approach and service delivery. It can also aid in refill count-based treatment adherence monitoring with distribution of NTEP drugs through private pharmacies with incentives to private chemists. This can be a bundled scheme within PPSA. That's what Dr. Kiran has mentioned, and Raj can add to this. But I just want to put one point. We can think of all these options, but online pharmacies or e-pharmacies are not yet legalized pharmacies in India. So far, there are no exclusive laws for operation of the e-pharmacies, and somewhere we have got stuck there. And going forward, maybe this can be a very good idea. He has also said about the post-marketing surveillance of ADRs of newer drugs and vaccines and pharmacovigilance program. Initial reporting can be extended with the engagement of pharmacists, definitely. And I'm very thankful that he has said that, because we have been trying to engage the pharmacist in the ADR program, in the pharmacovigilance program. And there is a committee at the government level where myself and Raj, we both are part of it, for engaging the community pharmacist in the pharmacovigilance program. Definitely. One more point from Mr. Rade, cough syrup cell surveillance has been tried and can really work well as the extension of surveillance interventions in NTEP. I fully agree with this, that cough syrup cell surveillance, it can work, because many people who come continuously for the cough syrup, asking for the cough syrup, are the people who are having chronic cough. And that's why they're coming to our pharmacies. In fact, in our projects, we have always trained the pharmacists to refer such cases to the public health facility for diagnosis, because they are the ones who are the suspected cases of TB. Yeah, definitely. So thank you, Dr. Kiran Rade, for all these inputs, and we will have more interaction with him. And I think this webinar has created a lot of interest, and we see many more possibilities of working together to enhance the TB care and control. And we can find solutions when we work together. I'm sure about it. And I think we need few more webinars or discussion meetings to take this forward. And this is just the beginning of a long road ahead, which I can see. I thank everyone, but I go back to Dr. Mohana, who would close this webinar in a few minutes. Dr. Mohana?
Thank you, Dr. Manjari. I would also like to express my heartfelt gratitude to our moderator, Dr. Manjari, for expertly guiding today's discussion and ensuring a smooth flow throughout the session. A special thanks to our esteemed speakers, Dr. Ravichandra, Dr. Raj Vaidya, and Dr. Saurabh, for their enlightening presentation and valuable contribution. Your insights have highlighted the critical role pharmacists play in TB care and elimination. A big thank you to all the participants for active engagement and thoughtful questions, which made this webinar truly interactive and impactful. Let's continue working together towards our shared goal of eliminating TB. Wishing you all a wonderful day ahead. Thank you so much. Thank you very much.